Hello and welcome to Everyday Oral Surgery. This is your host, Dr. Grant Stucki. I am an oral and maxillofacial surgeon practicing in Denver, Colorado. The goal of this podcast is to connect, learn, and inspire. In this podcast, you'll be hearing from OMS surgeons all over the globe discussing ways to improve the practice of oral and maxillofacial surgery. Most information shared in this podcast will be based on personal experience and opinions, so please supplement what you learn here with approved research studies. Without further ado, please enjoy today's episode. Everyone, welcome back to another episode. Today I'm with Dr. Andrew Jenzer and Rishad Shaikh, both oral and maxillofacial surgeons. Thank you for joining us on the podcast again.
Hey, good morning, Grant and team. Thanks for being here.
Good morning, everybody.
This is great. Andrew, do you want to kick us off on our topic today?
Absolutely. So first of all, again, usual disclaimer, please verify all information for yourself before using clinically. Today, I am super honored to have one of my best friends and one of the most amazing folks that I have had the chance of coming into the orbit of my life, of which I'm incredibly grateful, and that's Dr. Rishad Shaikh. We got to know each other maybe about 5-6 years ago now, and he's part of the core faculty for the St. Louis OMS review course coming up this October. Please come and join us, as well as one of the authors of the Blue Book. But Shaikh, I'd love if you would kind of go over for the listeners your story, where you trained, and kind of how you got to where you are today.
Thanks for having me again, guys. Grant, thanks for letting me on again. So not to bore everybody, but born and raised in Toronto, Canada, undergrad in dental school at Case Western in Cleveland, residency in West Virginia, and then a fellowship in St. Louis at Mercy Hospital in St. Louis, which is the program I'm still a part of. We still train 1 to 2 fellows a year, largely in trauma, orthognathics, TMJ, but there's a smattering of all sorts of kind of stuff that we do. And then, yeah, Andrew and I were serendipitously, connected through a mutual friend, Dr. Joe Ivory, 5 or 6 years ago, and luckily enough to have remained, good friends over the years. And he's honored me to be a part of tonight's discussion.
Yeah, and today I would like to continue our trauma series and talk to you guys today about nasal fractures, NOEs, and frontal sinus, and a little about skull fractures. So continuing our trauma outlook, and now we're kind of working up and in the upper part of the face today.
All right, you want to start us off on nasal fractures?
Yeah. Let's start with nasal fractures. So a little bit of anatomy things to just think about. We have 2 paired nasal bones. Superiorly, those attach to the frontal bone, and laterally to the frontal process of the maxilla. Inferiorly, the inferior edge of the nasal bones attaches to the upper lateral cartilage of the nose, and that's called the keystone area. The nasal septum, the big quadrangular cartilage, rests on top of the maxillary crest, and the nasal septum itself is thicker posteriorly and meets up with the vomer and ethmoid bones. And we have 2 plexuses that are kind of helpful to keep in mind. Anteriorly, the confluence of all that vasculature is called Kieselbach's plexus. Posteriorly, there's one as well called Woodruff's plexus. And those are both areas where you can get, a reasonable amount of bleeding, both in nasal trauma or just from nosebleeds. Shaikh, can you kind of walk us through an exam for a nasal trauma patient, or anything in particular you look at during those?
So this is going to be part of your general facial trauma exam. Again, for exam purposes, you're going to assume that ATLS has been completed and primary and secondary survey is done. And so now you're coming in and you're doing your concentrated head and neck survey. So again, you're starting from the top, from the from the hairline down, but when we get around to the nasal area, so I'm palpating the nasal bones, checking for crepitus. I'm doing a quick kind of airway assessment, how patent are the nares, and then you want to do kind of an intranasal exam as best as you can, depending if you're in a trauma bay and you may not have a ton of equipment around you, but if it happens to be an outpatient situation, depending on what the examiner has given you, you're in your office and you got a speculum and you've got a light, you want to let them know you're doing a good intranasal exam. If you want to go for those brownie points, you're even going to test for smell to see if they have anosmia, and that could be an indication of a cribriform plate fracture that might get you some bonus points. So palpating from the outside and a visual exam, at least externally on the inside. I don't know if get into right away talking about doing some sort of endoscopy in your primary nasal evaluation, but certainly hit the external and internal aspects of it.
Yeah. And when I'm thinking, just to touch on that, anosmia or a lack of smell, super important to not as much with nasal fractures, although because if it's a simple nasal fracture, it often will not be present. loss and affecting of cranial nerve 1. But in the regions we're talking about today with the naso-orbito-ethmoidal cribriform plate, it is a common side effect from these injuries, and it's very important to document that and think about it during your clinical examination. The other thing I always think about is ruling out a septal hematoma. If you take a look inside the nares, a septal hematoma means bleeding kind of coming and collecting in the septum. The 2 times that I've seen this clinically, and if you look at pictures of it, oftentimes that the septum is kind of swollen almost entirely laterally, that might be fully obstructing the nasal passage. And the times I've seen it, it's been bilateral. So essentially you're getting a lot of bleeding in the septum that is kind of ballooning things out. And you have to deal with it right away. This can be just localizing the area and then using something like a 15 to make a little nick. It could be using a needle to try to drain the blood off. But if you don't get that blood off, it's going to put pressure and eventually just destroy the cartilage of the nose, leading to typically like a saddle nose deformity. So that would be an indication that's something you have to treat right away. And similarly, very important to document that there's not if you have that. Thinking about kind of taking a step further, I think the value of in radiographs, plain films are a little bit outdated. Generally, most of us are going to have a CT scan if the ER doc has gotten it already, but I really like to have some 3-dimensional imaging because, as we'll talk about, I really try to think, is it just the nasal bones, just the nasal septum, or both? Plain films can't help elucidate that quite as much. Similar to like we talked about some of the other facial fractures as well, it can be quite helpful to ask patients for a photograph of themselves. What do they think their nose is now deviated to a new side or a different way? That can really help give you some context about what their normal nose looks like, because a lot of folks have deviations or twists already. And if somebody has a previously very bad deviated septum, the chances of you kind of breaking it back in place, not super high. So you kind of want to know where your start point is to kind of get back to that with treatment. Any questions so far, Grant? Anything we should touch on more about nasal fractures?
Oh yeah, just more about, yeah, I'm sure going to get into it next with the treatment and how you go about treating some of these complex fractures.
Yeah, let's start with timing considerations. Sheikh, how do you kind of think about when to fix a nasal fracture if they want it fixed?
Yeah, so if you don't have an acute nosebleed, you don't have a septal hematoma, then generally speaking, I'm typically waiting a little bit. What I generally tell patients, in some of this conversation we're having, a lot of it is obviously directed towards helping the listeners, taking their board exams, but there's also the real world application to this as well. And so generally speaking, I'm waiting, usually have the patient back within a week or so. And I tell patients largely indications for nasal bone fracture repair are either aesthetic or functional. Aesthetic because nasal bones are deflected and you don't like the way things look, or functionally your nares are not patent. So give it a week, allow swelling to go down, and then reevaluate them. So have them back in the office, do again a physical exam, externally palpating, internally looking at the nares, see how well how patent they are. And then if they've got concerns in 1 or 2 of those areas, then I'm scheduling them for repair. I'm doing this in an operating room. Can it be done in other settings? Sure, but I don't want to deal with posterior nasal bleeds and things like that in the office and with an open airway style of anesthesia. So I'm taking them to the operating room, assuming we're talking about an isolated nasal bone fracture, then they're being intubated orally, local anesthetic, in the perinasal area, local anesthetic along the nasal bones, along the nasal septum, nasal floor, using some sort of packing with some kind of hemostatic agent, either, cocaine is still used in a lot of operating rooms for hemostasis along the nasal septum. And then I'm going to reduce the nasal bones and if there's a septal fracture, reduce that manually. And then I am typically putting a splint externally and packing the nose internally majority of the time. Largely because of concerns of nasal bleeds postoperatively and avoiding that situation. And then having them back a week or so afterwards, pulling that nasal splint, internal, dressings anywhere from 3 to 7 days. And then honestly, the external splint, I just let fall off most of the time. Otherwise, I'll remove it in 2 weeks.
It's nice to hear that we do things very similar, Sheikh. I think location is such an interesting question. There is a lot of literature that has showed, and I discuss this with patients, what is the rate of revision required based on where you get it treated? And my mentor, Dr. Powers, has published some large studies in this area, but if you get it done in the operating room, the revision rate is somewhere around 4 to 6%. That will go on to need a septorhinoplasty or have an issue. For folks who get it treated under local anesthesia, that can be as high as 40%. So I am a big fan also of treating this in an operating room because it usually takes a number of times to get things lined up. What I found with people under local, you kind of get one shot, even if the local is pretty good, because they don't like getting things shoved down their nose, understandably. I went through a phase of doing these under sedation in clinic until I had a very, pretty bad laryngospasm with some nasal bleeding. So I am rarely, and under extenuating circumstances, will try under local if there's a very odd reason to do so, but generally I prefer to do this in the operating room. You can keep them on the bed. You don't even have to move them onto the table. You can just intubate or put an LMA and then you can do your thing. It's pretty quick, but you can really control it is what I've found. Pro tip, I think septal fractures are undertreated and almost always need to be adjusted. There's actually a couple of instruments that are made to help reduce a septum. And in particular, that's an Ash forceps or a Walsham. So they're these big kind of forceps that don't quite touch in the middle, and you can put them on the septum and then laterally bodily move it to reset it. A lot of times the significant deviations or curvatures of a nasal fracture are due to septal displacement, I think. And then you can kind of do the nasal bones, and that combination is super helpful. It's a lot more effective than just using the Sayer or the butter knife to try to reduce the septum. I also generally use some sort of packing agent. I don't typically use Doyle splints because I'm not cutting the septum open or doing manipulation. There's a product that I love called Nasopore, and you can think about it like gel foam for the nose. You put it in there and then it'll dissolve on its own in 1 to 3 days. Helps with like a little initial blood clot, but it's very easy. It's a little faster. The only time I'm going to reach for a stronger packing agent, and I kind of like Miracell, you haven't seen it or played around with it as a resident, I strongly recommend you cracking it. If you get Miracell and you put some water on it, it's kind of like those little dinosaur sponges you had as a kid where you drip water and they become much, much bigger. Same thing with Miracell and liquids or blood. So you put those packings in and then they expand dramatically. I like to do that if the septum is unstable. If it's still mobile and kind of moves as I'm setting things, in which case I'll take those out about 5 to 7 days later. Anytime you put packing in the nose, you should consider antibiotics because of the chance of getting a staph infection and leading to toxic shock syndrome. There are reports of that. Antibiotics in nasal fractures is a standalone. The antibiotics are controversial, and there's a lot of literature that shows kind of both ways. However, it's the packing that really pushes me one way or another personally. I have seen that toxic shock syndrome happen, and it can be a very dramatic thing. I like to do these a little bit on the earlier side, if possible. I've just found that sometimes after a week plus, and it really depends on OR availability, they can be really difficult to set. Once you start getting after 10 to 14 days, you can consider doing a closed reduction with a little bit of an open component by doing lateral nasal osteotomies. You can make little incisions internally and then use a chisel to kind of go up the lateral aspect to loosen it enough to move the complex. I don't do that frequently because if I can't get it very good or we're out that window, we can honestly usually just wait 6 months and then, septorhino. But I have seen it done and you can consider it. What do you think, Grant? Any other things you want to touch on?
I mean, any other tips that you guys use for closed reduction? And along with that, what are you doing after to check to see how reduced it is? I mean, do you do imaging after?
Good question. Yeah, I don't do imaging afterward, and I usually image most things afterward. I'm pretty strict about that. When I'm in the OR, what I try to do with my local is block everything around the nose. So bilateral V2 blocks, injections along the base of the nose, supraorbital blocks, afferent or some sort of agent inside. I try not to inject anywhere on the outside of the nose itself, and I usually don't inject on the septum if I can help it because I don't want to obfuscate the landmarks as I set it. Sometimes, especially if I'm doing it under local, I have to do a little bit of that. But if you set a light directly above the nose, you'll be able to see this light reflex just down along the midline of the kind of nasal tip and dorsum. I like to kind of mark that out very gently with a marker, and then you can look and see how that moves as you're setting it, just like you would do during a rhinoplasty. So applying a lot of those principles. But that can be quite helpful as utilizing that light reflex to see about how you're reducing things. I would say in general, it takes more force than resident thinks. Really setting these, especially septal fractures, It takes appropriate force, but it's usually more. And if you're going to do it, you really want to get the structures back in place. And it's not so much the popping the nasal bones up with a butter knife, but more about bodily moving that septum laterally, which takes a good amount of force to get it back in the right place, oftentimes from anything more than like a simple fracture. I don't know, Shake, anything else to add to that or pro tips that you like?
I know. I think the light reflex trick is a good one. A plastics attending of ours kind of taught us the same thing. Clean the nose off, get the dorsum a little bit wet, line that light overhead, and you can really see that light reflex. And he used that a lot, obviously in cosmetic cases, but that principle holds, for acute nasal bone fracture repairs. And then my other tip that my plastics attending used to determine how patent the nares was is, sounds funny and the nurses and everyone or get a kick out of it, but I lube up my pinky finger and I jam it all the way in. And if I can get my pinky down to the hub in both nares, then the nares are patent. And that's what he used to do. And that's how you check and see. And then he would take the butter knife and he would drop it into the nose. And if it just fell passively all the way down, he's like, oh, nares is open, and we'd move on. So those are tips I got from him that I continue.
I guess also in that vein, I'll often outfracture the turbinates at the same time to open up the airway and make them breathe better as well. Very, very easy and quick. Another procedure.
Yep, agreed.
Nice. Shake, do you want to take us start through the next one? Let's tackle the tricky and often scary naso-orbito-ethmoidal fractures.
Yeah. So NOE fractures, from an anatomy standpoint, it's the complex consisting of the nasal bones, the frontal process of the maxilla, the nasal process of the frontal bone, and the medial orbital wall that's typically comprised of the lacrimal bone and the ethmoidal bones. From an exam standpoint, they love talking about and asking about classification systems. So the Manson-Markowitz classification system is probably the one that most people are going to be familiar with. That if you utilize, it'll get across to the examiner that you have an understanding of this fracture pattern. And then it's got three types. They're all related to what the relationship between the central fragments and the medial canthal tendon are. So type 1 fracture is that there's no comminution of the central fragments and the tendon is intact. Type 2 is some comminution of the central fragments, but again, the key point is the tendon is intact. And then a type 3 is severe comminution of the central fragments and the tendon has been avulsed off the central fragments.
Nice. Yeah. And then, thinking about physical exam, obviously you could have if the structures around it are damaged, you could, like the nose, you could have all sorts of deformities, like a saddle nose deformity. You have crepitus, but really the thing we want to think about is telecanthus, right? That intercanthal distance should be about coincidence with the alar base. And you can do a bowstring test where you kind of put one finger inside that medial orbital area and then tug laterally on the inferior aspect to try to see if that canthus is still attached. And if you listeners do it right now, you can feel where your medial canthal tendon attaches there. And there are some differences, but most commonly we understand that the Caucasian adult, it's typically 28 to 35 millimeters for that intercanthal distance. It's pretty narrow, right? So translate that to centimeters in your head, and at a maximum 3.5, often less than 3. And that's going to be really important as we think about treatment strategies here. But a lot of times with type 3 fractures, I've seen distances of 60, 65, like it really gets larger. And we call that traumatic telecanthus. There's a different term that means the same thing for genetic conditions that cause this or syndromes, and that's hypertelorism. But important to understand those are two different things. There is something called bimanual palpation where, just like we were talking about nasal bone manipulation, sliding an instrument superiorly up in there and trying to wiggle it to see if it's loose. I have found that patients don't like or tolerate that well. So really CT scan is going to give us a lot of this diagnosis. And of course we're going to see potentially edema and swelling and ecchymosis. I always really check anosmia, right? Like we talked about. Paresthesia to the area. We could have other signs or symptoms of damage just associated with the usually severe injuries that kind of come around with this. You can, because part of this complex is the medial orbital wall, we could have orbital issues as well, right? Like anophthalmos or hypoglobus. And really, these are probably the most common fracture where you're actually going to have CSF leaking out of the nose, right? Rhinorrhea. And that can be subtle or very clinically obvious. I have seen it where every time their heart beats in time with their pulse, it squirts out this clear fluid. But it can also be this bloody, just leaky discharge that might not even look clear because there's blood coming from the nose. So how do we work that up? Well, definitive testing is a beta 2 transferrin test. You collect some of the fluid and send it off. There's almost always a regional lab that takes usually 5 days to result. There's something called a halo test where you drip some of it on a paper and kind of see if there's a center of blood in a straw-colored halo. The problem is the sensitivity and specificity of that is about 50 to 60%. So it's not that clinically helpful. What you really want to do is you want to collect some of the fluid and send it off for a basic metabolic panel because you can look at the glucose and chloride. The glucose should be about 2/3 of that found in blood, so usually about 60 or lower, and the chloride should be a little bit higher, and this is in the CSF as compared to blood. So that can be probably the best test between you actually getting the beta 2 transferrin lab back. And obviously, if you have concerns for this, this is where you want to get neurosurgery involved on the front side of it. Question so far, Grant? Anything we can cover more about at least the workup of an NOE?
What's the most common cause of NOE fractures in your guys' regions or what you're seeing?
I see them most often associated with MVCs, sometimes interpersonal trauma, but a lot of those, assuming they're not getting hit with a weapon, is usually more like orbital fractures or cracks in the area. But truly like disrupting that region, we actually don't see these as much anymore. They used to be a lot more common fractures before seatbelts became a big thing, because you would hit your midface into some, forward part of a car during some sort of automobile accident. So the incidence has really, I think, dropped, except on things without seatbelts. So I've seen a lot of these from ATV injuries. I think the other big category that I've seen is a lot of gunshot wounds. Missiles or projectiles or penetrating injuries going through that area, which are obviously have a, lot of other things going on, but often disrupt the NOE area. Jake, what about you, man?
I agree with you. We saw a lot of these in West Virginia, a lot of ATV accidents, getting headbutted by horses, getting kicked by horses. So fair number, I would agree. Nowadays not quite as much with airbags. You're not impacting that portion of your face on the steering wheel. The only other comment that I'll make in terms of physical exam, especially when it comes to a testing scenario, but in real life, I haven't seen rhinorrhea with an NOE, but I've seen epiphora with it. And so being comfortable talking about how to evaluate the nasolacrimal apparatus, and you're going to get asked about Jones 1 and Jones 2 tests. This is where they're going to hit you on these things, determining whether the obstruction is in the canalicular system or whether the obstruction is in the nasolacrimal sac itself. So just something else to think about in terms of your workup or physical findings. But again, real world application, do we see a ton of these? No, not a ton. They tend to be part of other panfacial injuries, but I think again, a horse kick to the face, that was one of the ones that sticks out to me. Yeah.
And honestly, I think that's one of the things that makes these so scary is that you just don't see them. So when you're dealing, especially with a bad one, have a very low threshold to take your time to call your friends and get other people involved to get some experts. As we're about to talk about, there is a lot of variation with how you can treat these. Oftentimes, like Shake was saying, that if you have a pan face, and the problem is, how do you get access to that area in one thought process? If you have to do a coronal anyway, neurosurgery considerations, then great. You're already there and could potentially do some things. And there's a number of incisions, and you can reference a book to look that involve direct access. I have to make an extraoral incision, which is pretty unusual to get there. I will actually make a small horizontal incision kind of right on the top of the nasal bridge. You'd think that a vertical incision kind of through those little bunny lines, if you frown, would be better at hiding scars. But the problem I found with a vertical incision there is it causes a lot more medial webbing and scarring around the medial aspect of the eye, which leads to all sorts of vision problems, and it's really hard to fix afterward. I got involved with a number of different ophthalmology secondary cases trying to fix some of that stuff, and it's actually a nightmare. So a small horizontal incision can be a good adjunct. For type 1 and 2 fractures, you can think mostly you're just putting bones back together. So, if you have the coronal down, using very small plates to try to do so. If you are putting plates in this area, it is one of the least forgiving areas in the body because the bones are so small. So what I really tell my residents and think about is you kind of get one shot to drill it and put the screw in. So you really want to take your time optimizing your drill angle and position and very gently screwing whatever you're going to put in there. Just really take your time. I think the crux of the question really comes down to what do we do with the type 3? However, I do want to talk briefly about something that my mentor, Dr. Powers, does that has pretty much obviated the need for any open treatment of these. And I think it's helpful to first start with a reasoning. It's such a narrow area that when you skin off that whole area, like let's say you do a Lafort style incision from the bottom and are working up, you do a coronal and get from the top, and then some like the pictures where the skull has these big curvy plates through that area, and you put all the bones back together. The problem is they usually look terrible afterward. And they still look wide despite you doing all the things correctly. What happens, and if anybody of the listeners has ever gone back in to take hardware off, when you get to a plate, how much scar tissue is around that plate? A millimeter, 2 millimeters? Often, right? A big, thick scar thing forms. So when you deglove that area, you put plates on and all that scar tissue builds up, it really ends up widening the area almost regardless. We don't respect how much the soft tissue is really required to make that area correct. So for any type of these, 1, 2, or 3, you can use either as a definitive treatment or as an adjunctive, a percutaneous NOE treatment. And that's actually a CPT code you can use. I'll walk you through it briefly here. I think Dr. Powers is working on a big publication, but from asking a lot of senior surgeons around the country, a lot of folks do this. It's just not a widely published technique. So something that I try to teach in any cadaver labs or courses that we do. Very briefly, you take a thermoplastic nasal splint, you soak it in hot water until it gets kind of malleable, and then you set it so that the wings of it are really up into the medial canthal area. And as you're setting it, whoever's doing it is compressing it quite hard. And this is kind of the key. On the table, I've gotten fractures that are 45 to 50 down to 35 or less. So I'm compressing that area with a thermoplastic nasal splint, and then somebody else pours cold water on it to set it. And if you're not compressing enough, you just throw it away or get it malleable and do it again. Once it's set, I usually use a 2-0 Prolene on a Keith needle or straighten the needle out, and I put a couple stitches widely through the nose itself in almost a horizontal mattress fashion. And then I stitch it in place. And what that does is it compresses and really helps give you that hourglass shape of the soft tissue. And in even type 3, it can hold the medial canthal tendon kind of where you need it. And then I leave it on for 4 to 6 weeks until the swelling goes down so much that it becomes loose and superfluous. And it does an amazing job at really getting that beautiful, tight, soft tissue hourglass shape in there. So it's a very nice adjunctive technique, or can be used as a standalone for any of them. And frankly, even if I'm opening the whole area for a pan face, I'll still do this at the end to really help the soft tissue and alleviate that widening with all the scar tissue as much as I can. And then, I'll just finish with the wiring thing and then turn it over to you, Sheikh, here. Transnasal wiring is a very, very difficult thing, even in experienced hands. There's a lot of ways that it can go wrong, which is why it's regarded as difficult. I would recommend, and so, like most people, if you're trying to figure this out, what do? You go to YouTube and check out videos, right? Most of the videos are from outside the US, and a lot of them show surgeons using like a suture on the inside to grab the medial canthal tendon and then do whatever resuspension they're going to do. A lot of these smart old surgeons that I've asked strongly recommend against this, because what can happen is typically a 2-0 Prolene, well, within a week or so, it almost acts like a cheese grater. It ends up ripping through and then boom, they're suddenly wide again. So if I'm going to do this, I'm going to use a barbed nasal wire. It's a special thing that is made to set into the medial canthal tendon to kind of grab it. So I would strongly recommend to our listeners, don't use a suture if you have any other option. One of the tricky things about the transnasal wiring is you essentially if you look at the AO website or a lot of things, you have to drill from the side of the fracture or somehow get the wire across and then plate it in place so it's held there. Paul Manson was famous for saying you can, never put a medial canthal tendon too posterior and too medial. So you want to try to get as much as you can, knowing that it's going to relax and have scarring issues. The problem is that drilling or passing of an awl across the nasal complex A really easy way to mess it up is you do it too anteriorly. If you, listeners, if you feel where your medial canthal tendon is, it's quite posterior in relation to kind of the bridge and dorsum of the nose. But drilling across there, you're worried about hitting the globe and all these issues, even with retractors. So you really have to do it quite posterior, more than you think, to make it work. The last thing I'll say is that I usually treat these ipsilaterally. So I'll say we're working on one side, I'll pass the barbed nasal suture. I'll lay a curvilinear plate kind of above it that kind of curves into the posterior superior orbit and kind of comes up the frontal bone. And then I'll suspend the medial canthal tendon to the most posterior screw hole of the plate with the wire, and then simply wrap it upward and secure it by wrapping it halfway around a screw when the screw is halfway down, and then finishing there. So even if I have a bilateral, I'll do it, both of them ipsilaterally, to avoid all the complications that can come with transnasal wiring, because it's so finicky and difficult to get right. I'll get off my soapbox, Shake. There's a lot of stuff. Please, what are your experiences, thoughts with NOEs? And if you, yeah.
I'll reiterate a lot of that. They are very difficult. The open ones that I've traditionally done that I can think off the top of my head, they've all been part of a larger, panfacial complex. So it's interesting. My plastics attending from residency, he did that same thermoplastic technique. I don't recall if he tried to capture the canthal tendon with his suture. It wasn't a big splint. He'd really cut it down and just basically have, like two wings over the bridge of the nose in that medial canthal region. But found that worked really well. Yeah, and I agree. The open ones that I've done, I don't think I've opened any isolated ones. Again, the isolated ones show up very often anymore. No. And the bigger ones that are part of, a bigger panfacial injuries, we've got a big coronal that's flapped down. I agree with Andrew that getting that vector is really difficult. The only time I've done any kind of transnasal wiring and transnasal suture, and I agree with you on using a barb suture. Only thing I'll say is that I do it on the contralateral side, just because I feel like I can get more of a superior vector a little bit, and I feel like I get more of that medial pull, but getting posterior is really difficult. And again, I'm going contralateral because that entire nasal complex is just chiclets, and so I can kind of easily pass things. And then I'm putting it in some sort of dorsal strut. If you've done a coronal, you've had access to calvarium, take a piece of bone. So I'll pass my sutures and then lay a piece of bone over the nasal dorsal structure to kind of reconstruct that part. But again, everything else, I'm in agreement with Andrew. Very difficult. The vector is tricky. Same thing. I'm taking the small plate, hanging it off the frontal brow. I'm leaving one hole that's open at the bottom, and I'm using that hole axis to kind of pass the barb wire through and get that posterior, superior, medial pull, and then tie it down.
And I guess one more pro tip that I'm kind of thinking about is, we talk about it like it's easy, but finding that medial canthal tendon can be quite hard. So the way that I like to do it, and the way that I would recommend all of you listeners try it in cadaver labs, is when you have that coronal down, you put one finger on the outside, like, of the eye where the medial canthal tendon is, and on the inside you could just use a pickup, and where you think in that area, you start to just grab and tug a little bit, because once you find the right area and you pull, you'll feel it exactly on your finger, and that's where you want to capture. It's kind of like a tug and pull until you really try to find it, but it can be quite hard. When you're going to put your barbed canthal suture in, I usually put it just behind the caruncle, and you can just pass it in, or you can make a very tiny little mucosal incision to help the barb kind of sit inside there. But take your time, because you kind of only get one shot at this. There are probably surgeons who are smarter than me who know how to revise this when it goes poorly, but that is beyond my skill set. I think it's a really, really difficult thing to fix secondarily. And might be more in like the cleft craniofacial world about, people who osteotomize that area. But I would not be comfortable fixing or trying to revise one of these, just because it's so finicky, unpredictable, and you can't win with the scar tissue there. It makes it really hard. So try to make sure you do it right the first time. And to me, that means if I'm struggling, calling somebody else in to help, really making sure I have a strong plan in place before we go to the operating room. What do you think, Grant?
When you're doing your thermoplastic technique, are you passing your 2O Prolene through the stent?
Yes. Yep. Through the stent and through the nose. Not so much like if you're picturing the listeners viewing the nose from the lateral aspect or the side, I'm getting like at least a couple millimeters down from the nasal bridge. So I'm going like through a good chunk of nasal tissue. And I usually put two in, one kind of up higher and one lower. Although you can also, there's a separate technique, I think a little bit more like Dr. Shaikh is describing, where you can do an acrylic button or just a little button that's only in the medial canthal region. But I really like, that whole nasal splint to be kind of just wrapped up into there, but also holding the rest of that complex to help with it.
Is there any, and then how do you get that splint to stay? Is there adhesive? Is there like, how does that
Yeah,
stay on there for a
good
while?
question. Yeah, there's kind of a number of steps, including like you can usually the sutures and the swelling that they have are enough to keep that kind of basal layer in. But it's there might be publications on it somewhere, but it's funny. Asking surgeons like Powers, Larry Cunningham, a lot of like really big names in our field. A lot of these people who do a tremendous amount of trauma have been doing this for like 20 years. It's just not like a widely published technique. So um, if you're thinking about it or want more information or have a case for it, reach out to me. I'd be happy to walk you through. I have some PowerPoints of my own that I've done them on that have like step-by-step instructions with more of the nuance, but it can be a really helpful tool in the tool bag to help deal with this area.
That's cool.
Yeah. Well, let's keep rocking. What else do we have in that area? The good old frontal sinus. If you have the chance to break it with during a cadaver lab, it can really clue you in for how much force it takes, but it's somewhere between like 800 to 1600 pounds of force to fracture it. So it takes a lot of force to fracture that area, which is why a lot of times it's associated with NOEs or other similar things, right? I'm thinking about, spine fractures, of course, brain injuries in this area. Within the frontal sinus, the fluid in the mucosal drainage system exits through the ostium located kind of at the posterior medial portion of the sinus floor, the nasofrontal ducts or the nasofrontal outflow tracts. Some people have a dividing wall between the left and the right side that's fully a full dividing wall of bone. Some just have a little bit, some have none. Some small percentage of the population has no frontal sinus or a very, very small one. So there can be some variability here. And that tract drains out into the middle meatus of the nose. When we think about classification system for frontal sinuses, I would say there's actually a lot of them, and it's a kind of argumentative topic. There's not like as much of a definitive classification like the Markowitz-Manson for NOEs, but most people think about Gonti's classification. Gontys. And that's kind of describes where that it's hurt. So type 1 is be an anterior table only. Type 2 is anterior and posterior. Type 3 is posterior only, and type 4 is comminuted. I think one of the tricky things to think about is how much is displaced. So a lot of folks, if the bone is displaced the more than the width of the bone itself, that's kind of mild to moderately displaced, and severe is kind of more in the comminuted area. But it doesn't take a lot to really mess this area up. And thinking about generally if the fracture is anterior table, posterior only, or both really helps you think about treatment options and what and why you would discuss with the patient and then potentially do. Here, CT scan, I'm really carefully going through it and looking for evidence of pneumocephalus, which is air in the brain that would indicate some kind of fracture in the posterior table. Also thinking about brain injuries, right? Extradural hematomas, arachnoid hematomas, the C-spine. So really trying to understand the level of involvement with the brain and potentially, getting neurosurgery involved. Shaikh, what about physical exam stuff for frontal sinus injuries? What do you think?
Yeah, I mean, so again, this is part of the whole complex of the face, specifically in this area, looking at the swelling in the frontal brow region, lacerations in that area, numbness that could be indications of injuries going through the supraorbital foramen to the supraorbital nerve, supratrochlear nerves, things of that nature. Air emphysema, rhinorrhea, potentially, from that aspect. I was just going to point out that on your CT exam, so you're going to utilize the axial cuts to kind of evaluate those anterior and posterior tables. And you're going to utilize that coronal cut to really try to visualize that nasofrontal outflow tract and see if that is involved. From the standpoint of repair and who we're repairing and why we're repairing it, again, this goes back to the difference between an exam and the real world. I would say on the exam, you're probably going to talk about, patient who's got a deformity that's greater than the thickness of the width of that anterior table, and or whether there's involvement of the nasofrontal tract. And that's largely part of my real world indications as well, but more so also the cosmetic aspect. So again, typically I'm allowing swelling to go down, evaluating the cosmesis, and if there's a cosmetic concern and or if the nasofrontal tract is involved, and we're worried about nasofrontal tract disruption that might cause mucocele and things of that nature, and then those are my indications to open and repair.
Yeah, I would agree with that too. It's anterior table is usually cosmetic, but a lot of times they do need it because it'll be like a golf ball sized divot in their face. It is so great when these patients have big lacerations over the area because then you just go through the lac and you don't have to do a coronal approach. Fixing these, and let's say we have a coronal down and open, and it's just anterior table, you really want to utilize mesh. You can use both small mini plates to put big chunks back together, and then you could put mesh over that if you want, but using mesh along with self-drilling screws a lot of times allows you to, not that it's required, but pull some of those bony chunks up and out a little bit. And this kind of gets us into thinking about testing it. So anytime I'm treating one open, I will always test the nasofrontal ducts. The goal is to essentially inject a substance and then see if it comes out the nose. It's kind of gives you that warm and fuzzies that the tract is open. I think I've tried a lot of different things and settled on propofol as being the best because I can see that kind of squirting out. I found that methylene blue tends to stain everything a tremendous amount. So asking anesthesia to sterilely give you some propofol and using it on like an 18 gauge angiocath. The nice thing about the frontal sinus is when you actually have it open, it's kind of like a kitchen sink. There's only one outflow tract, assuming the brain's not involved and you're not injecting into the brain. But it's one little kitchen sink, like little hole in the bottom, and that's where you inject and look there. And this is brings us to that thought process of, okay, like what do we do with these and why in terms of leaving it versus obliteration or cranialization? So those terms mean a little bit of different things, and I want to be clear about that. So obliterating it implies that you're removing all the contents and filling it up with something because of excessive damage to the drainage system and the concern for things building up in time. I think the indications for obliteration are pretty small these days, and most of us don't really obliterate hardly ever because our ENT colleagues or frontal sinus surgeons can endoscopically go back in and remove things. So if I'm treating anything that's relatively normal, even if intra-op it's not draining very well or I have concerns, if it's not a horrendous injury, I'm usually getting a post-op CT about 4 months after and referring to my ENT colleagues to potentially go in through the nose and open the duct back up. Cranialization implies that we're removing the posterior table and letting that space become part of the brain. So most of the time that I am removing all the contents and doing the full Monty, it's in conjunction with removal of the posterior table and cranialization. And that's often for gunshot wounds that have went right through the thing and just destroyed the entire area. So some of the things that I think about with that is, remember this area, we have pseudostratified columnar epithelium, part of the respiratory tract, and we have the foramina of Breschet. And those are little invaginations of that mucosa into the bone, which means that you have to be really aggressive, appropriately aggressive, I should say, about removing all of those. Because if you leave a little bit, it's going to grow, and then they'll either have a mucocele or a mucopyocele afterward. They can up to 20 years later. And I have seen that. It was really impressive. So if I have everything open and kind of in the hard mode here, oftentimes we're doing this with neurosurgery. So neurosurgery will typically start off with a bifrontal crani, removing the skull kind of picture above the supraorbital rims. When you take that off and you're looking down in the frontal sinus, it's this little pocket of bone area. It's really easy because you can see into it and you have access to the whole thing. What I'll do first is I'll use a curette. I'll scoop out all of the sinus lining. The bottom parts, I'll try to invaginate and tuck them down into those nasal frontal ducts. And then, like most answers in our world, a multi-layer kind of closure is going to happen in that area. But then I use a round burr to go gently throughout the entire sinus to really make sure that I remove all those minute invaginations. The posterior table usually gets removed with a rongeur. It's pretty easy just to clip away, and then that's kind of your cranialization. You can reconstruct that back part with mesh in certain circumstances if you need to. You don't have to. If you're doing it in conjunction with like a cribriform plate fracture and a CSF leak, This is where we'll often put multiple layers inside underneath the brain to kind of stop the CSF leak. And that can be things like tensor fascia lata from the leg and or pericranium from your coronal flap posteriorly. You can actually get a big piece there. So all sorts of agents kind of there along with some other neurosurgical agents. And then in the where the nasofrontal ducts, I've tucked it in. I'll often put some bone chips, some membranes. I'll put to seal, and then I'll fill that area up with fat, usually harvested from the abdomen or a distant site. Like usually, if I'm harvesting tensor fascia lata from the leg, a lot of times I can harvest fat from there at the same time. If you haven't seen what I'm describing, it's actually pretty easy when you're doing it with neurosurgery because you have the whole thing open. I think it's much harder to do if you're trying to obliterate it but not violate the posterior table, which there's just not many indications to do these days. Because of frontal endoscopic things. Shaikh, what do you got in terms of this? Similar to what you think about things, or
I know I think a lot of that is similar. I think, at least in the institutions that I've historically been in, if there's a posterior table component with the anterior table, neurosurgery is just doing the whole thing. I don't know if I've been called in many times for neurosurgery just to identify and treat the posterior and us treat the anterior, especially if there isn't more of a panfacial component with it. So I think for most of our listeners, again, in the context of, an exam, we're going to be talking about isolated anterior table, identifying the fact that there could be posterior table components and not ignoring that in your workup. But when they're actually examining you on techniques and repair strategies and accesses, they're talking about the anterior table and how are you going to access it and what are you going to do with that nasal frontal outflow tract. And again, real world versus examination, a lot of overlap. Again, same thing, use propofol to test the nasal outflow tract. I typically don't obstruct it and obliterate it unless it's completely blocked off. If I see some propofol coming through, then I'll try to maintain it. But for the purposes of an examination, hey, if there's concerns, yes, I'm going to obliterate the tract. I'm going to use, all the things that Dr. Jenzer mentioned, any kind of bone chips, gel foam to seal, block it off. Make sure you remove all the mucosa. Now, if you've got a true septum isolating the the frontal sinus on one side versus the other, then you don't have to go to the contralateral side. If it's not involved in the fracture pattern. But if it's one big frontal sinus, then yeah, you're technically, examination wise, you're removing all the mucosa, going in there with a little pineapple burr or round burr, trying to remove any remnants. And then, yeah, you can obliterate it however you want to. Real world application, I'm maintaining that pericranial flap most of the time. And so if I just need it, then I'll use it. I'll put it into the frontal sinus. I find I'm not going after abdominal fat very often anymore, but certainly, that would probably be the workhorse of you really want to get rid of that dead space, go to the abdomen, take a bunch of fat, pack it in there. The question always is, what's happening to that fat? Ultimately, it's lost its blood supply. Same thing we talk about when we do TMJ surgery, people about putting fat in there in replacement of a disc, if you've done a discectomy or things of that nature. Don't really know what's happening to that fat, but from an exam standpoint, say you went and got some abdominal fat, you filled the sinus cavity, and then you close things up. Largely the same.
And I guess one thing I didn't mention too, if it's one big area and one duct is blocked, but the other one is patent, you're okay to leave that if they still have an outflow tract. That usually will end up being fine. I have seen it once. So the problem is if you do a bad job of cleaning this out, you can have a mucocele. The mucus just keeps getting made and building up, or a mucopyocele where it gets infected up to 20 years later. So some reasonable follow-up plan for these patients is not a bad idea. The one I saw was 20 years after a helicopter injury with a helicopter blade to the head that the person survived. 20 years later, started presenting with seizures. The mucocele was, I think, 11 by 10 centimeter, like almost a tennis ball, and it got so big it was putting pressure on the brain and causing seizures. That was quite impressive when we went in there with neurosurgery and cleaned out and removed. The bad things can happen, so being really careful to take out all this stuff is just critical if you're going to do the full Monty and get rid of it. Grant, what do you think, man? Any questions in this area or closing thoughts?
No, that's a great summary. I mean, I remember some reason the foramen of Brichette showing up in an on-site exam, and I was like so confused, like what the crap is that? So I had to look it up, but no, this is all really helpful to go through each one of these steps and know the algorithm and be able to answer this if you're in a testing situation. Any other pearls, thoughts you guys have on managing these types of fractures?
As we get and we're touching on some of these variants that can be really complicated. I think the super important thing is you're never on an island, right? You almost always have a tremendous amount of time to plan these things. You don't have to make these decisions in a void or a vacuum, and you don't have to feel like you know all the answers. It's do the same thing that I frequently do. I pick up the phone, call Shaikh. Hey, what am I looking at? What do you think about this? You have a lot more friends and resources, from mentors to folks like us. It always makes me feel very honored when somebody calls me about I had 2 folks call me this week about some various trauma cases. And bouncing those ideas off of can sometimes really help before you go to surgery or fixing mistakes. But you don't have to know everything nor feel comfortable with everything, right? But be humble enough to pick up the phone and call a couple people to help give you insight, because it's the beautiful thing about our profession. There's a lot of folks who want to help you take care of patients better. So especially, in the more complicated things, it starts to get scary. Ask for help, get help involved. And similarly, if you're in a situation at a tiny place and you don't feel comfortable, you're probably better off transferring that patient first. Treating a lot of these more complicated things secondarily after somebody's done a not so good job the first time is exponentially harder. That is something I have learned. So it is okay if you don't feel like your skill set or the tools you're at a lot of hospitals don't have the particular stuff that you need, or access to CT navigation introp or introp CT scans. Just transfer the patient to a higher level of care from the jump. I don't think anybody's ever going to fault you for doing something like that. What do you think, Shaikh?
No, I agree with you. We had an expression in my fraternity: no man is an island, right? So you need help. As I've gone through my career, I'm solidly mid-career, maybe headed towards the horizon here. But you can't do this on your own. You need support. This profession of ours is very stressful. It's not something that we talk about much in training or in the early years. But you need friends, you need support. So, one of the benefits of being in the group practice that I'm in currently is that, I've got those guys around. Dr. Ivory grabbed me the other day and said, "Hey, come look at this orbital fracture with me. I got questions." So if you need another pair of eyes, reach out to somebody, have somebody take a look at it. And, remember the oath that we took, right? Do no harm. If it's out of your wheelhouse, be humble enough to say, "Hey, I got to send this to somebody else." And there's nothing wrong with that, because it's what's in the best interest of the patient. So I will echo both of those sentiments. And, if you need another pair of eyes, Dr. Jenzer and I are always available. Shoot us a text, email, take a little video of your fracture, scrolling through the CT and send it to us. We're happy to give you, from colleague to colleague, our opinion as to what we think is going on there.
Yeah. Great pro tip on reaching out to colleagues, and thank you guys for being willing to field questions and to explain all this. This has been fantastic for me, and I think our listeners will really enjoy this episode.
Thanks. I appreciate everybody. Thanks, Grant.
We appreciate Grant very much, man. Thanks for the opportunity.
Have a good rest of your day. Thank you.
Thanks,
Take
guys.
care. Bye.
Thank you so much for listening to this episode of Everyday Oral Surgery. For more information on these podcasts, please visit everydayOralSurgery.com. I love feedback and would be very grateful if you would reach out to me via my email, grantstucki@gmail.com, and let me know what you thought of this episode. Or you can text me at 720-441-6059. Additionally, if you have any topics you'd like to hear about, or if you would like to be a guest on the podcast, please email or text me. I found many of my interviewees through people who have been contacting me and have been listening, and I've gotten so many great ideas for more podcasts, and that's what helps keep the podcast rolling. So I really appreciate you making that extra effort and helping me out with feedback and knowing what to do next on the podcast. Thank you so much.